Hi everyone, welcome to another presentation in the HSVMA Continuing Education webinar series. We're really glad that you could join us tonight. My name is Lorna Grandy and I'm a consultant with HSVMA, helping to coordinate these continuing education webinars, and I'll be your moderator tonight. HSVMA is very excited to once again be partnering with the Association of Shelter Veterinarians to bring you this webinar. Both Dr. Bushby and Dr. McCobb are very popular speakers, and that's reflected in the number of you that are out there attending this webinar tonight. So we're very excited about that. But before we get started, I want to go over a little bit of technical information, and at the same time, you'll be watching in the background some photos from some of our HSVMA programs. So all attendees are muted, so we don't have to listen to each other's dogs barking, although you may hear mine. If we do have any technical difficulties, we hope that you'll be patient and we'll try to resolve them as quickly as possible. You will have a better listening experience if you close out all other programs on your computer. But if you do have trouble with the reception on this presentation, know that we are recording it and that you can listen to the archived version later. Most of you out there tonight are either HSVMA or ASV members, and we thank you very much for helping us to accomplish our mission. So please let me tell you a little bit about HSVMA, although I am going to kind of abbreviate our introduction tonight so that we can have a little bit more time with an ASV introduction. The Humane Society of Veterinary Medical Association is a national association for veterinarians and veterinary technicians founded in 2008. Our focus is on animal health and welfare. HSVMA provides a forum for veterinary professionals to advocate, educate, and serve. We work on national as well as state legislation, and our largest service program is RAVS, Rural Area Veterinary Services. So if you'd like to learn more about any of these HSVMA programs, please get in touch with us. So I just want you to know that you don't have to be writing everything down about this webinar. We will be sending you a follow-up email that will have all of the links that are mentioned in the webinar and also a PDF of the presentation. So just sit back and enjoy. If you have questions, we'd like you to type them into the questions section of your control panel. And at the end, we will get to as many of them as we possibly can. There are a lot of attendees out there tonight, and we are sure that this is going to bring us a lot of questions, so we will get to as many as we possibly can. So tonight's topic is a very important one, and we are very, very proud, like I said, to be partnering with the Association of Shelter Veterinarians. And I can't imagine two more qualified professionals to discuss the updated ASV Spay-Neuter guidelines. So let me introduce our speakers tonight. Dr. Emily McCobb is a 2000 graduated from Tufts Cummings School of Veterinary Medicine at Tufts University in 2000 and obtained a Master's of Animals and Public Policy also from Tufts. She completed a residency in anesthesiology and pain management in 2006. Dr. McCobb is a board-certified veterinary anesthesiologist. She is the director of the Tufts Shelter Medicine Program and is also director of the Luke and Lily Lerner Spay-Neuter Clinic, assistant director of the Tufts Center for Animals and Public Policy, and a clinical assistant professor of anesthesia. As program director, she supervises the on-campus Spay-Neuter Clinic, which serves over 2,000 animals a year. Dr. McCobb works to support community programs at the Cummings School and assisted in opening the Tufts EdTech Community Veterinary Clinic. The mission of the Tufts Shelter Medicine Program is to teach veterinary students best practices of surgery and medicine while sensitizing students to the needs of underserved animals. Dr. McCobb mentors veterinary and graduate students for clinical work and for animal welfare-related research projects. Her published works cover the topics of shelter animal welfare and animal cruelty, as well as clinical anesthesia and pain management. Our other speaker this evening is Dr. Phil Bushby. Dr. Bushby is a 1992 graduate of the University of Illinois College of Veterinary Medicine. He completed an internship and surgical residency at the Henry Berg Memorial Hospital at the ASPCA in New York City. Dr. Bushby is a board-certified veterinary surgeon who served on the faculty at Mississippi State University College of Veterinary Medicine for 36 years. Although he recently retired from Mississippi State, he still holds the Marsha Lane Endowed Chair of Humane Ethics and Animal Welfare and works at the college part-time. His primary focus has been spay-neuter, taking junior and senior veterinary students to animal shelters in northern Mississippi, providing basic wellness care and spay-neuter services for animals eligible for adoption for over 20 years. This service significantly increased the adoption rate at the participating shelters and provides students with an exceptional surgery experience. Dr. Bushby serves on the board of PetSmart's Charities, Mississippi Spay and Neuter, and previously served on the board of the Association of Shelter Veterinarians. He has received many well-deserved awards, including the ASPCA's Henry Berg Award, the AVMA's National Animal Welfare Award, and ASV's Service Award. Dr. Bushby speaks extensively nationally and internationally on the importance of spay-neuter, efficient spay-neuter techniques, and pediatric spay-neuter. Please help me to welcome these wonderful ASV speakers, and please take it away.
Well, thank you. This is Phil Bushby, and I'm excited to be here with you tonight. I'm really excited about the number of people that have registered for this webinar. Wanted to start with just a little bit of history. How did we get to this point? In 2006, a national task force to advance spay-neuter was created. It was funded by PetSmart Charities and the ASPCA. It consisted of specialists basically across all the relevant disciplines to spay-neuter: surgeons, anesthesiologists, internal medicine specialists, critical care specialists, epidemiologists, and veterinarians that were out in the trenches doing high-volume spay-neuter. And the real purpose of this task force was to look at the concept of spay-neuter clinics. They were spreading across the country at that time. They were sometimes controversial, but we wanted to look at the entire spectrum of high-volume spay-neuter. One of the products from this task force was the publication of the Association of Veterinarians Veterinary Medical Care Guidelines for Spay-Neuter Programs, published in the AVMA Journal in July of 2008. But knowing that things in medicine never stay static, the ASV knew that they would want to periodically update these guidelines. So in 2013, they reconvened the task force. The focus of this second spay-neuter task force was specifically to update these guidelines. Again, funding was provided by PetSmart Charities and the ASPCA. There were 18 veterinarians involved. Epidemiologists were really the only category left off on this second task force. If you look at the spay-neuter guidelines, if you looked at the original 2008 version, there were 4 broad categories: preoperative care, anesthetic procedures, surgical care, and postoperative care. The 2016 guidelines, ones published in July of this year, added 2 more broad categories: patient care and clinical procedures, and guidelines for operations management. And what we intend to do tonight is to kind of hit the highlights in each of these categories to give you an overview of the guidelines, and we'll leave you at the end with references where you can download the guidelines and capture more details. The association really values, we recognize the importance of high-volume spay-neuter clinics. We support the development of high-volume, high-quality spay-neuter programs with a focus on the importance of high-quality care to each individual animal. The ASV strongly believes that high quality and high volume not only coexist but support each other. So anyway, we encourage veterinary participation and public participation in these clinics. We encourage referral. The client who can't afford to have their animal spayed or neutered at a full-service veterinary clinic, those clinics can refer to these high-volume, high-quality programs. But we also recognize that sometimes not everybody lives up to standards, and we really encourage everyone involved in spay-neuter to maintain the highest medical and surgical standards. All right. As you read these guidelines, or as you go through the presentation, we had to keep it relatively broad. There's a little bit of a challenge here in developing very important standards to maintain highest quality, but recognizing that there's MASH style units, there's mobile units, there's standalone spay-neuter clinics. So in some situations we had to keep the guidelines quite broad just in order to accommodate all the models of high-volume, high-quality spay-neuter programs. So now we'll turn it to Emily McCobb, who will start the presentation on patient care and clinical procedures.
Okay. Thank you very much, Dr. Bushby. So I'm going to do the first part of the presentation, just going through an overview of the guidelines up until the part at which we have the patient anesthetized. I just wanted to say, as I get started, being one of the newer people to the team, I was added to the task force in 2013. And I like to joke with Dr. Bushby that, there was one anesthesiologist for the first go-around, but our section is really the most important, so they had to add 3 anesthesiologists for the second go-around. But anyways, I just wanted to take the opportunity to say thank you to everyone at the ASV and the sponsors for inviting me to be a member of the task force. It was really a great experience. As you all know, listening, spay-neuter people are really the best people to work with, and so it was a great honor and privilege, and really learned a lot. I think everyone on the task force learned as much as we contributed. So. The guidelines, as Bushby said, are outlined and divided up into these different sections, and it starts really before the patient gets to your clinic with how you sort of set up your clinic, with everything is designed to have the best service for the patient and the client, but also to build in efficiency. And really, as we went through the process, the goal was to have the highest standards, but to not make those standards so beyond what folks could achieve. So reasonable, but the best standard for the welfare of the animal. And you'll sort of hear that theme repeated as we go through the topics tonight. So the first section refers to patient care and clinical procedures, and that covers everything from the transportation of the animal to you, to the kind of protocols you need to have in place for housing, disease control, emergencies, and follow-up. And we'll go through those in a little bit more detail. So firstly, transportation, and certainly the spay-neuter guidelines are not intended to be a substitution for the guidelines that we have out there for transportation of patients, and in particular ASV and AVMA have put out updated patient or animal transport guidelines, and so those are out there. This is in no way mean to substitute for that, but we felt that it was important to sort of state that if patients are being transported to your clinic for the purposes of surgery, and in some areas of the country this could be considerable distance, it is within the purview of spay-neuter to make sure that those standards are adhered to. So that includes things like having the animals properly confined, not having loose carriers in the back of a truck, making sure that animals are identified properly as they go into the transport, and and when they get out, and that it's an appropriate vehicle for transporting as far as the climate control for the patient. And then, depending on the distance, there are standards for how often the animals need to be monitored and checked. And whenever possible, and this is another theme you'll see us mention a lot tonight, whenever possible, we should be incorporating strategies to reduce the stress on the animal, because we all recognize that moving animals to our clinics for surgery is a big stress on them. And anything we can do to make that better is ideal. Next is record keeping, and firstly, another theme that you'll hear Bushby and I mention is that the guidelines are never intended to take the place of federal, state, or local laws or regulations. So anytime there may be a difference between what your local or jurisdictional regulation is and the guidelines, the recommendation is that you go with the more stringent recommendation. So the guidelines are really supposed to be a substitute, or not a substitute, a supplement to existing regulations, not a substitute. For every animal, obviously they must have a medical record, which is a legal document, and we must record our physical exam findings, body weight, the doses of all drugs that are administered and how they're given, a record of the surgery, and any abnormalities that were identified. And certainly most of us are using some sort of standardized medical record form for efficiency purposes to make things easy and rapid, but that should allow for modification if necessary. So in the top of the slide, I'm showing the sort of standard Humane Alliance check-in form that most of us are using, and there is space on that form to add additional things that you may find. On the bottom, I'm just showing one of our PA tags that we use in the TNR clinic. So this is just really an index card that we use during the clinic, and it gets turned into the electronic medical record, but it still is recording all the things that are required by law. So it serves as that cat's medical record while it's in the clinic. Vaccination was sort of a hot topic during the task force discussions. This is one of those things that's a little bit tangential to our spay-neuter mission, but many of us are administering vaccines at the time of surgery. Ideally, of course, we would prefer that the animal be up to date on vaccines before it comes to us, but we recognize that that's not always possible depending on the population and the community that you're working in. And so for the interest of the health of the animals, it is acceptable to vaccinate animals around and during the time of anesthesia, and that's been shown. There are several published studies that the vaccines are protective and that it is safe and acceptable to do this. The task force sort of drew the line at saying, at sort of stipulating what you must do in terms of vaccinations, but again, you need to comply with state law. We all felt strongly that vaccination against rabies should be strongly recommended, and that also we should follow the guidelines established by the AAFP and the American Animal Hospital Association as far as which vaccines to vaccinate for. So there's more detail about that in the document itself. Again, now that the animal has arrived at the clinic, we're going to continue to do the best we can to ensure that we have safe and low-stress handling. The animals need to be identified individually, and the cage as well. Attention to the temperature of the clinic is something that I think we don't put as much attention to as we should, but we want to make sure that it's a comfortable temperature for the animal and not just for the surgeon. And sometimes that's a challenge for those of us that work with students because we don't want to have it too hot, but it's really best to make sure that we don't get hypothermia from the get-go because our hospital is too cold. We want to keep our animals separate, so especially cats and dogs, and if you're doing rabbits, it's not good to have the rabbits near the predators, so we try to separate them as well and make it as quiet and as stress-free place as we can, and then disinfecting between patients. So there's more details on that in the document as well. In general, every animal is housed in an individual cage, although it is acceptable according to the guidelines to put housemates or litter mates together up until the time that they're pre-meted. And then if we're working with animals that aren't socialized to us and aren't volunteering to come to surgery, we can keep them in our traps and whatever devices we have that allow us to be able to anesthetize them with a minimal of handling. One of the things that was added was the thought that we should pay particular attention to when we are moving sedated or anesthetized animals so that we're not causing any additional pain or injury to those animals, and just making sure that we keep the animal that its body position level and ensuring smooth transport from place to place just when we're moving around the clinic. All of the things that we do in our normal day-to-day operations in our shelters in terms of being vigilant about preventing infectious disease would come into play in the spay-neuter clinic. Firstly, the animal itself. So during our preoperative physical exam, we need to make sure that if we are identifying animals with infectious disease that we're separating those animals and then following our sort of normal procedures for sanitation and preventing the spread to additional animals. And that includes things like batching equipment. So if you have groups of animals coming from particular sources, keeping those animals together, and if it's a large volume of animals, you can have designated equipment for those animals. That just minimizes the array of things that get spread if you have a mixed population. Another important aspect of clinical procedures is being prepared, and so recommending that everyone do CPR drills, that you have somebody, and that could be the veterinarian, but there needs to be at least one person in any spay-neuter setting who has been trained and knows how to respond to medical emergencies. A lot of us, do work with volunteers and lay staff, but you definitely need to have someone at the clinic who is kind of your go-to for the emergencies, and making sure that everybody knows where the equipment is and where your algorithms and things like that for what to do in an emergency, where that's posted. Veterinarians should pretty much always be available to triage and address complications as long as animals are, anesthetized and recovering from anesthesia. They need to remain on the premises until the animals are alert and responsive, just so that you have you make sure there's someone there in case of a problem. You want to train your staff and your volunteers, as appropriate for their level of involvement in the clinic, but they should be trained to recognize emergencies, and then you should have designated staff who are trained in CPR. You also, even if you're in the field, and a lot of us work in pretty unusual locations when it comes to medical procedures, but you still need to have your standard emergency equipment. You need to have your drugs and your reversal agents readily available, and emergency drug charts. One of the things that I learned by going through this process was that we hadn't done regular CPR drills with our staff in our clinic in quite a while. So we instituted kind of an annual or semi-annual process where we just run through our drills by really kind of thinking about how the guidelines could be applied. And that's a thing that that I would recommend for everyone, is that go through the guidelines and audit what you're doing in your clinic. And I found several areas in my own clinic that we had a little bit of room for improvement. So I think that's part of all of us kind of striving for the best practice. You need to have a procedure for your clinic for how emergencies are going to be handled. What the policy is. The client needs to be told who to call and what to do if there's an emergency after discharge. It's ideal if the spay-neuter clinic sees its own complications back for re-exam, but a lot of us, I know Bushby, for example, often travels quite a far distance, so he may not be able to see all the emergencies in that program back right away. So if that's not possible, you need to set up a contingency plan, so who it is that's going to provide the emergency care, and that should be on the discharge information so the client knows. And then, if you do have a sort of catastrophic event and lose a patient, which at the volume that many of us are doing, to some extent is inevitable, the program needs to be notified, and then ideally a necropsy performed, and all of this information and statistics needs to be tracked. Okay, so moving into sort of away from the general clinic procedures and starting to focus on our patient, there are many things that go into providing a good spay-neuter experience that start before we even get them anesthetized. So starting with patient selection, what we communicate to the client, and then getting our patient ready. So the most important point about patient selection that's highlighted in the guidelines is that it's really up to the veterinarian. And so ultimately each clinic is going to have its own policies about who their patients are and who they're able to serve and who they're not. But ultimately, even down to the individual patient level, it's the veterinarian's decision. Certainly, you know, the timing of spay-neuter and all of this is getting to be more controversial in our field, and we have a wide array of opinions, but most of us feel that for the owned pets it may be best to schedule surgery at 4 months of age or older. Again, that's at the clinic's discretion. On the other hand, if it's a shelter situation, everyone's getting spayed and neutered prior to adoption, and we know we can do that regardless of age. Most of us in spay-neuter, we're still pretty confident that neutering before sexual maturity is strongly recommended for our own pets. And so again, those types of decisions is going to be clinic to clinic in terms of your who it is that you're serving, and there may be individual animals that may or may not fit your criteria depending on what's going on to them. So that we leave that up to the veterinarian. For example, in spay-neuter we're always sort of talking about the risk-benefit. So for example, there are things, mild infectious diseases or other non-infectious medical conditions where in a typical private practice setting or like where I am in the teaching hospital, we may choose to wait. But we know in the spay-neuter situation, depending, you know, how much what the community is like, this may be a once-in-a-lifetime opportunity to get that animal spayed and neutered, and so we want to weigh that against the risk of the animal. And in many of these mild medical conditions, we know that we can anesthetize them safely and the animal will do very well. So things like upper respiratory infection, subclinical heartworm disease, parasitic infection, pregnant lactating animals, animals in heat, pyometra, all of us anesthetize these animals on a regular basis with good results. So it's a matter of assessing what your clinic and your setting is capable of handling, assessing the risk of the animal, making sure you're communicating that risk to the owner or agent of the animal, and then putting plans in place. But again, as far as whether an individual animal would go to surgery that day, that's the decision that the veterinarian would make. Client communication is very important, and in many of our clinics, our staff members, our veterinary technicians and assistants are assisting with this because of the volume of animals that we're bringing in. So, but certainly we still need to get a patient history if we have an owned animal or even a shelter animal, if it comes with any information, anything about its prior life or prior anesthesias in particular, that all needs to be obtained from the client. The client needs to understand not to feed the animal, and then we need to make sure we have that conversation about the risks of surgery and anesthesia, and then we must get informed consent from the agent or the client. One of the things that has been updated in the guidelines for the 2016 was a little bit of updating the recommendations of fasting. In general, in veterinary anesthesia, we're moving towards shorter fasting times, similarly to what's happening in the human anesthesia field as well. Again, depending on the age. So for the really tiny guys, the pediatric patients, we're really not recommending much of a fast, so they should definitely have a small meal 2 to 4 hours prior to surgery, and then definitely do not hold food for these little guys any longer than 4 hours. And then the juveniles, we do like to fast them for a minimum of 4 hours, but you don't need to fast them any more than 6 hours. Many of us still do the overnight, so the typical sort of no food after midnight, and that's acceptable for the animals, you know, over about 4 months of age. The guidelines, this was another heated debate, but the guidelines do allow for an exception for feral cats in traps. So if it's not safe to remove the food from the trap, it is acceptable to have the food in the trap until he comes into the clinic. And then certainly it's not necessary or recommended to withhold water. And you know, in a lot of areas of the country, we've really gotten rid of sort of the low-hanging fruit. And that means we're anesthetizing more challenging populations of animals, including older animals that, you know, you wouldn't typically have seen an older animal in the spay neuter clinic maybe 5 or 10 years ago, but now we are seeing more older animals. So especially for those geriatric guys, you know, make sure the clients are not holding up their water prior to anesthesia. The physical exam, according to the guidelines, it must be performed by the veterinarian or a supervised veterinary student. It's performed prior to anesthesia when possible if it's a tractable animal. You definitely need to verify the reproductive status of the animal. An accurate weight is really important. And then there's a couple of things that we typically do in a standard physical exam that we may or may not be doing in spay neuter. So we may or may not be taking everybody's temperature. That's again at the veterinary's discretion. And pre-anesthetic blood work is another thing that we don't usually do in spay neuter. And the good news is that there's really not a lot of evidence that pre-anesthetic blood testing on a healthy animal is necessary. So that's good news there. But we still need to do a thorough physical exam, making sure that the animal is cardiovascularly fit and that they are not at any increased anesthetic risk. If we do identify an increased anesthetic risk, then that needs to be communicated to the owner. Okay, so we're switching now from the preoperative and patient care section and going into the best section, the anesthetic procedure section. It is the longest section. So that includes everything from thermoregulation of the patient, the equipment that we use, how we're going to manage our airway, fluid therapy, how we're going to monitor the patient under anesthesia, the protocols, pain management, and then dealing with waste gas. And then there's a little section at the end talking again about higher risk patients in spay neuter. And so maintaining thermoregulation is a big theme in the guidelines, and what we say is that you really need to start this as soon as the patient enters the clinic and up until the time that they leave you. And so some of the strategies there can be avoiding drafts, keeping the animal dry, protecting them from cold surfaces. So don't put them down on that stainless steel exam room table. Use a towel, use a barrier between them. Avoid excessive prepping. This time of year we're still doing spay neuter free roaming cats, but we're being really careful how much we're shaving and not wetting down the hair excessively, using near warmed prep solutions, and really trying to limit the time the body cavities are exposed. And then all of our active patient warming strategies, so our recirculating warm water blankets and bear huggers. You want to be really careful, so we discourage the use of things like hair dryers and electric heating pads, which have been known to burn patients. Many of us use containers that are warm, so warm water bottles or the pet safe things, and those type of items are fine, but we recommend that you place them in the patient's microenvironment, not directly against the patient. It's when you put those items right up against the patient that they can be burned. So making sure that they can have a barrier, and then also making sure that once the animal is up and able to move around, that they can get off of the heated surface. So you don't want to put them in a completely heated area with no way of them to get off. For your anesthetic equipment, the procedures in the spay neuter guidelines are basically referring back to sort of your procedures for any veterinary clinic, so that the kinds of equipment checklists that you use would be the same as in any practice. But because we are doing such a high volume of surgeries, many of us, we can expect more wear and tear on our equipment, and so we do need to be vigilant about checking for those things. So all the equipment needs to be checked every day. You need to be doing your leak tests every day. You should have a regular maintenance schedule for your sotasorb and all your components of your machine. You definitely need to have something to address waste gas, and we put in the guidelines some links and resources for recommendations there. And that can be an active or a passive scavenging system is acceptable. So even if you're in the field, you should be able to set up a passive scavenging situation that complies with our spay neuter guidelines. Oxygen is required. So not all of our patients in spay neuter are going to be on oxygen if you're using an injectable only protocol, but you need the ability to provide oxygen when needed. And for certain higher risk patients, such as those that are overweight or very pregnant, or some of our brachycephalics, animals like that, we're going to recommend that you do supplement them with oxygen during the surgery, even if it's normally an all injectable protocol where you are. You need to have an ability to provide ventilation to them, and so that could be via the anesthesia machine most commonly. So we're just going to hook them up to the circuit, and using our CO2 absorbent we can ventilate for them. You also need to make sure you're using an appropriate oxygen flow rate for the circuit that you're using. If you're not using an anesthesia machine, if you're in the field or something like that, you can have an ambu bag. So you have, but you know, regardless of where you are, you do need to have the availability of oxygen and the ability to ventilate the patient. Capnography is something that's addressed in the monitoring section. It can be very useful to assure the adequacy of the ventilation and that everything is working correctly. So that's recommended, but not required. Another sort of hot topic in spay neuter is how to manage the airway. And so routinely intubating all of the patients is not required. However, the ability to perform intubation if needed is required. And there are certain patients that we would strongly recommend that they'll always be intubated. So those would include our friends, the brachycephalics, anyone who's very overweight, anyone in advanced stages of pregnancy. Sometimes if they have severe upper respiratory disease and their nose is going to be really clogged up, it can be safer to intubate them. And then anytime you're expecting a longer surgery, so you know your big dog space, those are situations where you want to at least consider intubating the animal if you don't normally do that. Some people have interpreted this sort of relaxing of the intubation requirement that's in the 2016 version as, oh, I'm intubating, so now I need to stop intubating. And that's not at all what we're saying. What we are saying is if you're in a situation where you aren't routinely intubating your cats or dogs for procedures that are short and animals that aren't falling in these high-risk categories, then that is acceptable. If you are intubating, you need to make sure that you're verifying the correct placement of the endotracheal tube, usually through direct visualization or through the use of capnography. So similarly, for fluids, it's sort of similar. So you're not required to administer fluids. It's rarely necessary for every healthy spay neuter patient having a very short spay or neuter. However, the ability to administer IV fluids if it's needed is required. In certain situations it would be recommended. So if you again have a very advanced pregnancy, if you have a sick pyometra, any pyometra wouldn't be a bad idea if you have the capability. If you experience unexpected blood loss, if the surgery is longer than it should have been, or any type of high-risk situation, the ability to administer fluids is recommended. Monitoring of every patient is required. So certainly the hands-on monitoring, monitoring the pulse quality, the rate and rhythm, the respiratory rate, and the depth of anesthesia is something that needs to be done on every patient. All of these things can be done by your technician, and then certainly you can add in the objective monitoring devices. So having some sort of audible electronic continuous monitor is also helpful, and that can be either using a Doppler, a pulse oximeter, which I would argue is the monitor of choice for spay neuter, and really everyone should have a pulse oximeter on their patients. Capnography, again, is ideal, but probably used only in about 25% of clinics, maybe slightly higher than that now at this point, but that's ideal if you are intubating the patient and you have that monitor. And then blood pressure, really, if it's anything longer than 20 or 30 minutes, is something you would want to consider. But most of our surgery times are going to be under that. So the most questions that I get tend to be about the anesthetic protocol, and we tend to give the least specific information about this because there is a wide variety, and exactly which protocol is going to be right for you is going to depend on sort of the surgeon preference, the efficiency of the surgeon and the type of patients that you're seeing, and also the preferences and skills of your technical staff. So it's difficult for us to give you one prescribed protocol, but the guidelines sort of talk about the range of things that are acceptable and the types of criteria that you would want to consider. Also these days with what's happening with cost of drugs and availability of drugs, you know, it's good to be a little bit flexible because a lot of us change our protocols depending on what's happening with drug availability. What you definitely need to include, you must include analgesia. So the guidelines are very strict about saying that analgesics are not optional, that they are part of any anesthetic protocol, and certainly in spay neuter they are required. You want to put good consideration to stress reduction and anxiety for the patient. Also, we want to have good muscle relaxation and immobility for surgery. And then ideally, anytime you're providing general anesthesia, you're looking for a safe, controlled, reversible depression of the central nervous system. That's pretty much the definition of anesthesia. Always good jokes between surgeons and anesthesiologists, so Spay has that cartoon there. We always feel like we're waiting for each other, but we work it out. So we want to avoid one-size-fits-all dosing. So we want to dose based on the weight, and most of us are using charts because it's faster. So we have our chart of our doses based on the weights of the animals, and if you can't obtain a weight, then you may estimate, like for our free-roaming cats and things like that. But you want to increase your safety there by using reversible drugs and avoiding those drugs that cause really marked cardiovascular depression if possible. One note of caution, if you are using the charts, be very cautious at the edges of the chart. So the charts tend to be a little bit less accurate with your very tiny patients or your very large patients, and in those cases you want to maybe look at dosing according to body surface area or metabolic scaling, or double checking the calculation of the dose for that patient as sort of an outlier patient. Typically, the guidelines do goes into a little bit more detail about the types of drugs, so it's a little bit of discussion of the types of analgesics that we use, the types of drugs for stress reduction. We talk specifically about the concept of total intramuscular anesthesia, so depending on when you graduated from school, this is a little bit of a newer concept, so the idea that we can give a single injection that includes all the drugs that we're going to need for the, not just the sedation but the anesthesia for the surgery itself. That's sort of a refinement for many of us, and so many of us are using those types of protocols, and they do have the advantage of decreasing the stress for the patient, so it's just that single injection. The use of anticholinergics was a section that some of you might notice had changed a little bit from the 2008 version, and we just basically softened that a little bit. So in general, they're not necessarily indicated for every patient, but if that's included in your protocol, then that's fine. The one time that we are going to say, be cautious with your anticholinergics is when you're using dexmedetomidine. So when you're using the alpha-2 agonist, remembering that the bradycardia there is due to that particular anesthetic, and you don't want to treat that with an anticholinergic. If you're having trouble with that animal from not tolerating the drop in heart rate, then you want to reverse the alpha-2 agonist. Induction maintenance was another sort of controversial section. So, sort of the basic principle is that for reasons of staff and personnel safety, you want to avoid the amount of masking that you're doing in your clinic. So ideally, you're not inducing the animal with a gas anesthetic, and not just for the staff safety, but also because that can be very stressful for the animal, especially if it's not well sedated. So we recognize that there are situations where, for whatever reason, mask inducing that particular animal is what's needed to be done, but it shouldn't be your routine induction strategy. So there's enough injectable protocols out there that your basic induction should be one of them. Similarly, the use of the chamber induction shouldn't be your standard go-to for every animal. It's rarely needed, but we would never say that you should never do it, because all of us can think of those situations where that was what was needed. The mask maintenance is more, again, to do with safety of the personnel. It may be appropriate on an as-needed basis. There's evidence to show that intubating cats can actually cause more morbidity for them. So if you are not intubating your cats, you may be doing a little bit of masking with ISO. On the other hand, if you're doing a lot of supplementing with the mask, it may be that you need to adjust your anesthetic protocol, that you could tweak your injectables a little bit and get more time out of your injectable protocol and not need to do so much inhalant. And especially if you're working in a small space, like a mobile spay-neuter unit, the risk then of any leaked anesthetic gas to the personnel becomes magnified in that tiny space. So you just want to keep kind of the whole picture in mind in terms of what protocol you're using and everybody's safety, and kind of come up with the best for your particular situation. And then lastly, those higher risk patients, so with the milder diseases or any of the older patients or the brachycephalics, it's going to come down to that individual veterinarian as far as can that animal be safely anesthetized in your setting. And you may need, for that one patient, to consider an alternative protocol, intubate when you don't normally, change up your drugs a little bit. And having to do this is sort of counter to the idea of high volume, but as we're moving into different populations of animals, we may need to make some changes here. And it's very important that if you do that, that you communicate the risk to the owner so that they're aware and they're still, making the decision to go forward with the spay and neuter surgery, even though you've identified their animal as a higher risk patient. And we had some discussion about how to do that within the flow of a spay neuter clinic, and it is acceptable to use a delegate, so the technician or another staff person may contact the owner if something has changed from the time of admission to the time of anesthesia, just to make sure that the owner or agent is informed. And that's about all I have to say to get the animal under anesthesia. At this point, I'm going to turn it over to Dr. Bushby, who's going to start from the surgical section.
Well, thank you, Emily. Emily just successfully summarized about 2 years' worth of discussions in 30 minutes. Now let's see if I can do the same thing. We're going to talk about surgical care, postoperative care, and then clinic operations. From the standpoint of surgical care, some of this is very basic and won't be a surprise to anyone. Obviously, you need an appropriate operating environment. That does not necessarily mean a standalone surgical clinic, as Emily mentioned, or as we mentioned in the introduction. There's very successful MASH-style operations, very successful mobile spay-neuter operations. So it's simply important to maintain standards, minimize traffic flow, have appropriate equipment and appropriate environment for performing surgery. Obviously, the guidelines call for honoring Halstead's basic principles of surgery, asepsis, tissue handling. From the standpoint of asepsis, every patient should have separate sterile instruments. Sometimes that creates a little bit of confusion because it doesn't necessarily mean a separate sterile pack for every patient. It's perfectly acceptable to, if you have a high volume clinic where you're going to be castrating 20 male cats one after another, it's perfectly acceptable to sterilize a stainless steel container that has 20 layers of a paper towel, a hemostat, a gauze sponge, a paper towel, a hemostat, a gauze sponge. You open up separate scalpel blades for each, and each patient is getting surgery is being performed with sterile instruments and new sterile instruments for each patient, but it was all in one pack. All surgeries should be performed by a licensed veterinarian or a supervised veterinary students. And as I mentioned, Halstead's principles, gentle tissue handling, meticulous hemostasis, strict attention to asepsis, minimizing surgical trauma. The guidelines talk about having properly located small incisions for spay-neuter. Small incisions reduce tissue trauma. They reduce surgical and anesthetic time. So the concept of minimally invasive surgery is very relevant to spay-neuter. It can be done, you can have minimally invasive spay using a small incision and the spay hook, for example. Under specific surgeries, ovariohysterectomy or ovariectomy, the guidelines don't argue for one over the other. Both ovariohysterectomy and ovariectomy are considered completely acceptable techniques. Obviously, the main requirement is removal of both ovaries. In cats, the guidelines talk about the use of the pedicle tie. And some of you may not be familiar with the pedicle tie. I'm going to show a quick video of it, but it's an instrument self-tie very similar to what most people, most veterinarians use when they castrate a male cat. With a pedicle tie, we're simply cutting or tearing the suspensory ligament. This is an only cat, can only be done in cats, but it's a very useful, very successful, and very efficient technique. We've cut the suspensory ligament. We've torn a hole in the broad ligament behind the vessels. We're only dealing with the vessels, and we ligate those vessels with an instrument, not using any suture at all. My understanding is you will be provided, ultimately you will be provided with a link to the videos that I show in this PowerPoint. So if you're interested in learning the pedicle tie, if you've not been using it, you'll have access to these videos. The guidelines talk about various methods of ligating ovarian pedicles and uterine stumps or uterine bodies, and mentions the modified Miller's knot. I'll demonstrate the modified Miller's knot where the suture material is passed under the uterine body, passed under again, creating a loop. The needle holder is passed through the loop, and then a square knot is basically tied in a general manner. But if you watch this being tightened, the knot falls down under the loop. The loop collapses onto the knot. It holds the knot secure while you're placing 3 or 4 more square knot throws on top of it. You've essentially ligated with a double thickness of suture with a very, very secure knot. This can be used on, we use it on every single every single uterine body, whether it's a kitten or a Great Dane, and can also be used, it's a very secure knot that can be used on ovarian pedicles or other situations. The guidelines mention several different approaches, ventral midline, paramedian approaches, but cautions that the holding layer, the strength in a closure of an abdominal approach, of a ventral abdominal approach, is the external rectus fascia, and the necessity of ensuring that you securely close the external rectus fascia. Guidelines also talk about flank approach, and flank approach is very commonly used in some countries. It's not as common in the United States, but a flank approach can be very helpful when you're dealing with cats with mammary hyperplasia, cats or dogs that are nursing a litter of puppies or kittens. In our program, we use the flank approach routinely when we perform surgery on feral cats, community cats. We know these animals are not going to get the level of post-operative observation and care that an owned animal is going to get, and we know that a flank approach minimizes any risk associated with wound dehiscence after surgery. So we won't go through the entire spay here, but there's 3 landmarks for a flank approach. The last rib, the transverse spinous processes, and the cranial aspect of the wing of the ilium. And we make an incision that's 2/3 of the way back from the last rib towards the cranial aspect of the wing of the ilium and ventral to the transverse spinous process. It's irrelevant whether you make a dorsal ventral incision or a cranial caudal incision. It's really surgeon's preference. And when you've made that skin incision, and all we're going to do in showing this is we're just going to show how you find the first uterine body here. But when you've made that initial skin incision, you're going to encounter the external abdominal oblique muscle. You're going to encounter deep to that the internal abdominal oblique muscle. You might encounter the transversus abdominis. And the external and internal abdominal oblique muscle fibers run perpendicular to each other. That's why you have minimal risk of dehiscence. If your entire closure should break down, you still have those muscle layers that prevent any abdominal contents from exiting the incision. We're going to bluntly go through, we've made a skin incision, we've gone through the subq, we're going to bluntly go through the fibers of the external abdominal oblique and then the fibers of the internal abdominal oblique. And when you've done that, you may or may not have already penetrated the peritoneum. In this case, we had not penetrated the peritoneum. You saw me lift it up with the thumb forceps and snip the peritoneum with the scissors. If you've made the incision in the appropriate place, you're going to see one of three structures. You're going to see uterine horn, uterine horn, ovary, or fat. In this situation, I was able to look in. I could see the ovary. We do these with the animal in left lateral recumbency, so I'm on the right flank. We reached in, saw the right ovary, delivered it through the incision. That's how easy it is to identify or to locate the uterine horn or ovary in a flank spay. If what you see is fat, we'll use a spay hook, we'll pass it into the wound, and we'll sweep in a ventral to dorsal motion. And just like a typical spay using a spay hook, you'll be able to locate the uterine horn. And from that point on until closure, the surgical procedure is just like any ventral abdominal spay. What we'll do with for closure is we'll generally put one cruciate suture in the internal abdominal oblique muscle, the muscle itself. There's no heavy fascia associated with it. One cruciate suture in the external abdominal oblique, and then subcuticular sutures to close the skin. When you're doing a pregnant cat or dog, as long as you don't open up the uterus and expose the fetuses to room air, those fetuses stay unconscious and slowly die. There's no reason to attempt to individually euthanize the puppies or kittens if you've done a if you've done a surgery on a pregnant animal. When we talk about castration, again, the guidelines say that this particular technique you use are surgeon's preference. The requirement is that you remove both testicles, and you may have seen more in the literature in the last few years about the use of a scrotal castration. And again, for time's sake, I'm not going to show the entire castration, but I'll freak you out a little bit here, showing making an incision right on the scrotum. Obviously, prep of the scrotum is critical here. You want to clip the hair, but you've got to be very, very cautious about clipper burns. When we prep a scrotum for a scrotal castration, I like to refer to it, we leave like a 2 to 3 day beard. If we have a little bit of stubble of hair, we're not going to get concerned about it. The key with a scrotal castration, and there's been a couple of research programs that, research papers that have been published, is a lot of people were taught in veterinary school never do a scrotal castration in dogs because they'll self-mutilate. The reality is, in the research projects that have been done, castration through a scrotal incision resulted in less self-trauma than castration through a pre-scrotal incision. There's been at least 2 studies that have been published that confirm that. And scrotal castration takes about 2/3 the amount of time as a pre-scrotal. So whether you do pre-scrotal or scrotal, the guidelines don't really dictate. They just open the door to say scrotal castration is a perfectly acceptable technique. We then go on and talk, the guidelines talk about cryptorchid castration. And some of the textbooks talk about doing exploratory laparotomies to find abdominal testicles in dogs and cats. And I'm going to show a quick video here that the guidelines don't go into detail on specific techniques, but you can generally locate an abdominal testicle using a Spay hook. I'm making an abdominal approach here, caudal abdomen. The animal's prepuce is right here, so we're on the right side of the animal. This is a right unilateral abdominal cryptorchid. We're going to go in a right paramedian approach into the abdomen. I actually find in this area that the entry into the abdomen is the most difficult part of a cryptorchid castration. This technique takes advantage of the fact that the vas deferens in dogs and cats, if you trace it from the vas deferens from the normal scrotal location of a testicle through the subq, through the inguinal canal, entering the abdomen, the vas deferens loops around moves cranial and medial, loops around the ureter, and then goes caudal and medial to the prostate. And the location of that looping around the ureter is consistent regardless of where the testicle is. All right, so we're entering the abdomen here, right paramedian approach. We're going to place a Spay hook into the abdomen, just lateral to the bladder, and we're going to sweep lateral. The movement of the Spay hook is slightly lateral and slightly cranial, starting at the neck of the bladder and moving lateral and cranial. And as soon as we get into the abdomen here, which like I said is generally the more difficult part of this procedure, we sweep in, and there's the ductus deferens. All right. So you don't have to explore. You don't have to open these animals wide open and do an exploratory to find an abdominal testicle, as long as you understand the anatomy of the relationship of the vas deferens to the urinary bladder. And again, for time's sake, we're not going to show the rest of the surgical procedure, but I wanted you to be familiar with that particular technique. The guidelines talk about pediatric spay neuter, and as Emily said, there is some controversy associated with when you should do spays, and all sorts of things in the literature. But at least certainly in the shelter environment, or generally with the populations of clientele that routinely use high quality, high volume spay neuter clinics, pediatric spay neuter is certainly an acceptable technique. Pediatric spay neuter can be done as young as 6 weeks of age in the shelter environment. We certainly recommend that all animals be spayed or neutered prior to adoption from the shelter. And who gets adopted most commonly? It's the young puppies and kittens. It's not the older adult dogs. Guidelines talk about strict adherence to using biomedical grade suture or surgical clips, only materials that have been approved for medical use that are sterile and dated for current use. And it talks about the fact that you, with the exception of stainless steel, suture material should not be re-sterilized. Once the packet is opened and used, it should not be re-sterilized and be used in another patient. Stainless steel is an exception to that rule. There's been a little bit shift in the comments related to antimicrobials, the use of antibiotics. In the 2016 guidelines, the 2008 guidelines kind of really pushed back against the use of routinely using antibiotics. In the 2016 guidelines, the terminology was softened a little bit, simply saying it's not considered necessary, but if used, they should be used prior to surgery or as soon as there's a break in asepsis. Guidelines specifically mention the use of skin glue because we've seen lots of people that use it incorrectly. Skin glue should never be placed in the wound to try to glue the edges of the wound together. The wound should be closed and skin glue applied to the surface. When you apply skin glue in the wound itself, it simply becomes a foreign body which the body has to remove. We recommend that all animals that are spayed and neutered be identified. We prefer the use of a tattoo. This picture above shows, and we prefer using green ink. I like to describe it as that's because we've never seen a green dog or a cat. This picture above simply shows the use of green tattoo ink in the spay incision itself. Humane Alliance promotes what they call the scoring technique, where you make a small partial thickness incision adjacent to the original incision and put green tattoo ink in that incision. The green tattoo ink is there forever, and it avoids those situations that unfortunately happen too often in the shelter environment where someone goes in to spay an animal that was spayed 3 years ago, but no visible scar, no real evidence that the animal was spayed, and the tattooing prevents unnecessary surgeries. For community cats, we recommend the use of the ear tip, and the ear tip should be a straight cut, removing at least 1/3 of the pinna. Moving on to postoperative care, patients should be monitored closely as they recover from anesthesia. And it should be an environment that minimizes any risk to the patient or to the staff, an environment that allows continuous observation. It should be secure, a secure level surface. It should be clean and dry and warm. And a lot of people use what Humane Alliance coined the term the beach, which is a padded area on the floor in the surgical room itself. So you've got surgeon there, you've got people monitoring anesthesia there, you've got the ability to continually observe these animals, and nobody ever falls off the floor. So it's a very safe environment. You want to position the animal so there's no restriction of the airway. You can certainly recover pediatric patients with litter mates, and perhaps one of the exceptions to the whole thing with the postoperative care or postoperative monitoring is community cats that can be returned to their traps relatively quickly before they become conscious, before they become a danger to the staff. Obviously, you know, we've gone way past the age of not routinely using analgesics. Analgesics are required anytime you do surgery on a patient. The guidelines reinforce that requirement, but don't get into specifics as to what analgesic agents to be used or the frequency with which you use them. They do make the point that postoperative analgesics are not a substitute for minimally traumatic techniques. Right? So what are they trying to say there? Right? That you minimize postoperative pain two ways: by minimizing trauma during surgery and by the appropriate use of analgesics. It's not, oh gee, our surgery can be as traumatic as we want because we're going to put them on analgesics afterwards. No, it's both. And if you find that you're having to redose analgesics frequently, you should probably look at your surgical technique. When patients are returned to housing, you should verify their identity. Again, trying to make sure you keep track of each patient. Once they return to a cage or a run, they still need to be evaluated. They still need to be observed periodically. Pediatric or animals, kind of the special needs animals, should be offered small amounts of food and water as soon as they can. Dogs should be walked. Cats should have an absorbent substrate to urinate in. Patients should be evaluated prior to discharge. The skin edges, the wound edges should be clean and dry and well opposed. The patient should be sternal and alert and responsive, and dogs should be able to ambulate before they return to their owners. Trapped cats can be returned when they're alert and oriented and able to kind of move around on their own. There should always be both written and verbal postoperative instructions given to owners or caretakers. All right. Now, this is a new section. Operations management is a new section in the guidelines, and it deals with the issue of how do we manage these programs in a manner that maximizes the quality of care and minimizes postoperative complications, minimizes programs. What you're trying to do is deliver consistent, high-quality care with minimal errors, and it starts by defining all the steps in the system. From intake of the animal to discharge of the animal and every step in between. A lot of programs will have defined very specific protocols for each step of the procedure of the entire system, and everybody is trained to follow those protocols. The use of standard operating procedures and checklists are encouraged because they ensure consistent care. They help manage the workflow. They can be updated to reflect changes in standards or changes in guidelines. And many places have designed their medical record to also serve as a checklist. So as you're going through things and checking them off on the checklist, you're also creating the documentation of what was done in the procedure. There needs to be systems in place to collect data, and there needs to be systems in place to analyze the data, right? The only way that a system can consistently improve is by knowing exactly what they're doing, knowing what the outcomes of what they're doing are, and modifying their practices or their protocols when they see an issue. But if no one is looking, if you never know that there's a problem, then you're never going to fix the problem, is the simple way to state it. Right? The staff should be trained. Staff should be trained for each particular task that they are going to perform. Again, in some of these larger, higher volume clinics, you'll have certain staff during admission, certain staff involved in the preoperative care and the induction of anesthesia, certain staff involved in the postoperative care. The staff should be fully trained for the tasks that they're going to prepare, and they should be observed performing these tasks before they're allowed to do them unsupervised. Leadership these programs require a leader that understands how to work with people, that values their staff, values and empowers their employers. And we recognize that leadership skills can be taught. So when you have that clinic manager or clinic director, you want that to be a person that either has leadership skills or you want to develop those leadership skills. Again, for consistent performance and consistent improvement. When you consider that a high-volume veterinary spay-neuter clinic, each individual surgeon may be performing as many as 35, 45, or more surgeries a day, meaning the staff are handling that many animals per surgeon. You want to have an environment that fosters safety, that promotes the health of the staff and then helps the health of everybody employed. It's not just about high quality care for the patients, it's high quality care, if you will, for the professional staff that are working there as well. You've got to look at ergonomics. How many of you have seen surgeons, or how many of you are surgeons, that stand over a surgery table bent over so you can see well, or that always stand up for your surgeries, or always sit down for your surgeries, or always stand up and you're standing on a hard floor surface. So you've got to pay attention to the ergonomic factors that will reduce surgeon stress and staff stress, will reduce repetitive motion injuries. I did this wrong for so many years until I visited a high-volume clinic. Typical setup where each surgeon had 2 tables in their surgical suite, and this one surgeon had 1 table high, 1 table low, and she alternated her surgeries all day. Between one surgery she'd be standing up, the next surgery sitting down, one standing up, the next sitting down, and it blew me away what a simple thing that was, but how it reduced muscle strain and how it reduced backaches and how it made that surgeon not only more comfortable but more productive. I think Emily made this point, but it's worth reiterating. There's nothing in these guidelines that supersede local, state, or federal laws. All right? Whenever there's legislation that deals with the same issue as something in the guidelines, what we recommend is use the higher standard. So if the guidelines are a higher standard than the Practice Act, use the guidelines. If the Practice Act is a higher standard than the guidelines, use the Practice Act. All right, so a lot of material covered in a very, very short period of time, but just a few concluding remarks. One is spay-neuter programs have become a very important, very integral part of our veterinary profession. All right, and you've seen articles in the AVMA journal just within the last few months about underserved populations, how the veterinary profession is offering higher quality veterinary medical care than we were years ago, but at a higher cost, leaving segments of the population behind. Right. The profession has to come to grips with the fact that we have to have in place systems that fill in the gap, that provide some basic quality services to individuals who don't have the financial resources that we wish they all had. Maybe that's the best way to describe it. Following these guidelines, you can have high quality programs that are high volume and also low cost. The guidelines are available at these two websites. The easiest one is sheltervet.org, which is the ASV's website. And I've been asked to read a brief introduction of ASV. I guess I should have done this at the start and was brain dead. But anyway, the Association of Shelter Veterinarians consists of over 800 members and 32 student chapters from around the globe. The ASV seeks to advance and support the practice of shelter medicine in order to improve community animal health and well-being. In serving as the leading professional organization for shelter veterinarians, ASV has produced the Veterinary Medical Care Guidelines for spay-neuter programs, as well as the Guidelines for Standards of Care in Animal Shelters. On the organization's website, anyone can access these guideline documents, many relevant position statements, and information regarding various shelter medicine tracks at national veterinary conferences. Members of ASV can participate in our active community forum to chat with colleagues about a wide variety of shelter medicine topics. ASV members can also access a wealth of organized online animal sheltering resources. For further information on becoming a member of the ASV, visit our website at www.sheltervet.org. So, I think we're at the stage where time is slipping away and we have at least a little bit of time for questions.
Okay, that was wonderful. Thank you so much, Dr. Bushby and Dr. McCobb. That was really great. We do actually have several questions, and so we'll kind of go along in order here a little bit. So, Dr. Bushby, what studies support the decision to spay and neuter after 4 months of age for owned pets?
Well, I don't know that there's studies that specifically say that that's the ideal time.
Okay.
You know, there is controversy in the literature there. The after 4 months for pets is based upon trying to have the animals sterilized prior to sexual maturity, especially looking at females, trying to have the females spayed prior to them ever getting pregnant or ever getting to heat, coming into heat, but after their full vaccination series, right? So if you're bringing an animal into a veterinary clinic for spay-neuter, and this is an owned animal, it's not living in a shelter environment, but it's an owned animal, then there is absolutely no risk of delaying spay or neuter until after they've had the full vaccination series. Now, we could have another full webinar on what's the best time to spay or neuter, and we could get into an awful lot of the research that's out there on incidence of orthopedic conditions, incidence of tumors, pro and con, early age versus delayed. But that 4 months is simply let them get the full vaccination series, but have them spayed before they ever get pregnant or become sexually mature.
Okay, great. And I want to remind people actually that Dr. Bushby did do a webinar for us a little while ago. And so if you go to hsvma.org/webinars, there's an archived webinar about this conversation about at what age animals should be spayed or neutered. There's more information out there. There's more that's been published since then, but I think that's a great start if people are interested in learning more about that topic. Okay, so Dr. McCobb, you were talking about withholding food. But somebody was wondering about if you're using an anesthetic agent like xylazine that might cause vomiting, do you change that recommendation?
No, I don't change that recommendation. We still, for the pediatrics, don't recommend more than the 2 to 4 hour fast for the little guys, and a 6 hour fast is fine. For most animals, that whether it's a 6 or 12 hour and the xylazine is going to make them vomit, either way. So so no, it's just the 6-hour fast. The one thing that we did sort of get into some discussions about is with the food and the traps. So we use TKX, which has xylazine, in my clinic for free roaming cats, and I have quite a lot of cats vomit. So I do tell my trappers to not leave food in the traps because of the vomiting. Not a lot of cats, but I'll have like maybe a cat every other clinic or a cat at clinic vomit, and we have to clean up their airway, and I think that's a pretty good risk for them. So we do ask our trappers to not leave the food in the traps, but some programs felt like that wasn't something that was safe in their circumstances to do. And so we tried with the guidelines always to make it so that nothing would be so onerous that there would be someone who was doing for all intents and purposes, a good program wouldn't get into trouble with something like that. So we wanted to kind of leave that flexibility there. So you definitely will see some vomiting with alpha-2 agonists in cats, but a 6-hour minimum fast should be fine.
Okay, great. We have a lot of questions and not a lot of time, so I'm going to, so Dr. Bushby, I'm going to sort of throw a couple of questions at you. Someone is wondering how you close the scrotal castrations, and also a different question for you about, do you remove the sub-Q fat when you're entering the abdomen?
Okay. Those are both very good questions. From the standpoint of scrotal castration, I'm waiting for someone to do the next research project. There are on what's the ideal closure. This is what I can tell you. The ideal closure is not putting skin sutures in scrotal skin. That's where self-mutilization comes in. The historical teaching, don't do scrotal castrations in dogs because they'll self-mutilate, comes from the days when everybody was using external skin sutures to close wounds. If you avoid external skin sutures, you avoid the self-trauma. So where does that leave you? And within the high-volume spay-neuter world, there's kind of 3 schools of thought. One is, don't close them. We don't close them in cats. We don't close them in pigs. We don't close them in cows. What species do we close them in? All right. A second school of thought is close them with skin glue. Close them, but without using any sutures. And the third school of thought is close them either completely or partially with buried subcutaneous sutures. And nobody knows which one of those is best. This is what and one other thing we know about that. If you leave them open or partially open, client communication is huge because there will be drainage. And you don't want to do a scrotal castration on a client's animal and leave it open, have the animal run home, jump up on the brand new white bedspread, wiggle around a little bit, and then go lay on the carpet. You might be paying for a bedspread and carpet if you do that. So if you leave them partially open or fully open, they've got to be confined in an area where the drainage does not create a problem. All right. So that was a semi-non-answer to the how you close the scrotal castration question. From the standpoint of removing sub-Q fat when we're going into the abdomen of a spay, personally I do. I know a lot of surgeons don't, but let me tell you why I do it. All my years of being a spay-neuter surgeon has been working with students. And the most common mistake that students will make is attempting to close the body wall on one side of the abdominal incision to sub-Q tissue on the other side. And that
yikes.
And that mistake comes from not having good visualization of the edges of the body wall incision. So I will remove a little bit of sub-Q fat. I'll have my students remove a little bit of sub-Q fat, not because it helps in entry, but it facilitates the closure, the visualization of the wound edges for closure. If I had to live with, I got two choices of post-op complications, a dehiscence or a seroma. I'm gonna opt for the seroma every time. Removing of the sub-Q fat increases the chances of post-operative seroma, decreases the chances of a dehiscence. That's personal preference. I know lots of high-volume surgeons who do not remove the sub-Q fat at all, but they're not necessarily ones working with students every day.
Okay, interesting. All right, so Dr. McCobb, Robin is a little concerned about the fact that you said that it is not necessary to intubate dogs, and can you just explain that a little bit more, please?
Sure. So that is a very hot topic, and certainly the dogs that I talked about that would be higher risk, so your big large dog spays or your pregnant dogs or your brachycephalics, we're going to strongly recommend that you do intubate those patients. But in a lot of programs, they're doing puppies and they're using an injectable only protocol, and they're not intubating, and they're having short surgery times, so 5, 10, 15 minutes for neuters and spays of puppies. And so the reason we wrote the guidelines the way we did is that we didn't want to have someone then question what that program was doing and saying that that's not at the standard. So with a lot of your total injectable protocols, they're going to do quite well even in that scenario. Now, if you're a program that's using a different protocol and you are routinely intubating the dogs, that's totally fine, and you don't need to change what you're doing. So a little bit depends on the size of the animal, the age of the animal, and the protocol that you're using and the results that you're having. So in my program, we do intubate adult and puppies, but not for our scrotal neuters.
Okay. All right. So I'm going to, we are kind of going over time. We have a lot of people still on the line, so I'm going to assume that you would like us to continue with a little bit more, with a few more of these questions, but I'm going to recommend to most of you with your questions, I think you will find that if you went to the guidelines and read the guidelines, that a lot of your questions will be answered, because we're going to be leaving a few of you on the line with your questions unanswered, so we apologize for that. I think this is a really interesting question. Maybe you both might want to take a shot at it. Someone is wondering how we can change these laws and standards of care to be more flexible for the high-volume, high-quality spay-neuter clinics.
Would you repeat that question?
How can we change these laws and standards of care to be more flexible for the high-volume, high-quality spay-neuter clinics? I'm thinking this person is thinking that you have high expectations.
Well, I guess I would say that I think that, you know, the standards in these guidelines, they are actually pretty flexible, and if you compare the 2016 to the 2008, I think that more recent version, if anything, is more flexible. I think that, you know, there definitely is a need to sort of support this field and to be accountable to folks that are maybe less familiar with what a high quality, high volume clinic is, and so we certainly want to make sure that we can be held up to the scrutiny of those that might criticize the practices, and we're aware of lawsuits and veterinarians that have gotten into trouble. So we wanted to make sure that everyone has what we felt are, you know, completely defensible practices, and really it's about the welfare of the animal. And so I mean, obviously we're biased, but I think we feel that these guidelines are very flexible and that do apply in the vast majority of clinical settings in the United States, and that the ultimate outcome is a very good result for the patient, and that we're also in compliance with, you know, our local practice acts and things. I know, Bushby, you're maybe aware of some more of the legal situations. I'm not aware of any situations where sort of our routine practices that we all find to be acceptable and sort of the gold standard in spay neuter are in conflict with other regulations. I don't know if you want to comment on that further, Bushby.
Well, I'll try to, but I want to add to what you just said, and that is that we really believe that these spay neuter guidelines are appropriate in every situation that does spay or neuter. So the routine general private practice that does a handful of spays and neuters, we think if they followed these guidelines would be providing quality care. You know, so guidelines are not intended to be exclusive for high volume clinics, but very broad, even to the level of the private practitioner who might do 1 or 2 spays or neuters a day. From the standpoint of legal issues or whatever that come up, and if I step on anyone's toes with what I'm about to say, it's intentional. There are segments of the profession that are totally opposed to any system that provides lower cost veterinary care to individuals who can't afford full service veterinary, the prices at full service veterinary practices. I think the number of people in the profession that fight these systems is slowly diminishing, but it's still out there. And so we've had to become, especially in the second set of guidelines, we became aware of situations where practitioners or state boards would find a statement in the 2008 guidelines that either they would misinterpret or they would attempt to use to their advantage in filing complaints against veterinarians. And the best example I have is, I think that, and I won't remember the exact wording, but in the 2008 guidelines on what should serve as a surgical suite or surgical operating room environment, I think we used the terminology something like it should be reserved just for surgery. All right. But then we have practices out there that are using this beach concept where the immediate post-operative recovery is on a padded warm surface in the surgery room. And I'm familiar, in fact, I was an expert witness in a court case where one of the complaints against the high volume clinic was that violated the ASV guidelines because they were allowing animals to begin to recover in the surgery room. So a lot of thought went into the terminology in these guidelines to attempt to avoid providing ammunition to people whose motive was simply to eliminate these programs that help underserved populations. That's the best answer I can give.
Okay, that's great. All right. Well, thank you for that information, and I want to thank both of you so much. There really are still a lot of questions, and it's making me think that we may want to do a webinar sometime on troubleshooting specific in specific things in spay-neuter surgery, because there's a lot of very specific surgical questions that are coming up. So we'll keep that in the back of our mind for the future, Dr. Bushby, okay?
Yeah, you know, if it's appropriate, you might send me an email or whatever with all those questions, and that we might be able to use that to form the basis of the next webinar.
All right, that would be great. So thank you both so much. This was really, really wonderful. I want to remind our attendees that to get continuing education for this, you do need to fill out the evaluation form, and I want to let you know that our next webinar is going to be on Wednesday, February 8th with one of our most popular speakers as well. Dr. Nick Dodman is going to do spitting, sucking, and snapping, the many faces of obsessive compulsive disorders. And please note that this webinar will be at 7 p.m. Eastern Time and not our usual 8 p.m. Eastern Time, so feel free to sign up for it anytime soon, and we have a few other webinars coming up. So thanks everybody for attending, and don't forget we have our archived webinars as well. Happy holidays everyone, and we will see you next year. Good night.
All right. Thank you, folks.
Thank you.